Welcome to the first one of the Hazelhurst series, as we call them. Our first speaker tonight is Dr. Matthew Hall, Head of Gastroenterology Department at Sutherland Hospital, Clinical Lead, Direct Access of Colonoscopy Project, Southeastern Sydney Local Health District, and he's a committee member, the leading better valued care direct access colonoscopy for the Cancer Institute of New South Wales. He's also the co-chair from 2019 to 2021 of the New South Wales Colonoscopy Categorisation Guideline Agency for Clinical Innovation and Cancer Institute of New South Wales. Matthew has a long-term interest in improving the early detection and treatment of colorectal cancer as part of his practice as a gastroenterologist for the past 20 years. During 2019 and 2020, this interest has broadened to improve the accessibility and value of colonoscopy to the broader population. Matthew has been working at the Sutherland Hospital and Southeastern Sydney Local Health District level. He has extensively contributed to the 3 statewide committees under the Agency for Clinical Innovation and Cancer Institute New South Wales, leading to better value care direct access colonoscopy, improving the patient and GP access to colonoscopy services, and the mechanisms of delivery is core to these initiatives. So without further ado, Matthew, thank you.
Thanks, Phil. Thanks for the opportunity to talk. I'll just start sharing my screen. Does everyone see my screen? It's a PHN and Southeast Sydney slide.
Yeah, it's all good.
Thank you. So thanks again to Martina and Phil Dwyer and the PHN for allowing me to speak tonight regarding a topic that attracted my attention about 30 years ago. I was impressed with some of the early FOBT studies showing about a 33% improvement in bowel cancer survival for those doing FOBT. And this was despite a very small uptake of subsequent colonoscopy after a positive FOBT. There have been steady improvements in the way that colonoscopy and FOBT has been done over the last 10 or 20 years. However, there's still a lot of work to do in improving the patient uptake of FOBT and improving the patient access to colonoscopy services. Tonight I'll discuss these developments and improvements in service aimed to increase bowel cancer survival. So the learning outcomes for tonight, after attending this webinar, the participant hopefully will be able to improve the participation rates of colorectal cancer screening, particularly using FOBT, describe the patient-centred improvements in direct access colonoscopy model of care, utilise inclusion-exclusion criteria for direct access colonoscopy and how these help to provide a safe and efficient service. I'll briefly discuss the GP management of the patient after having a colonoscopy. After my talk, Martina will talk about and demonstrate health pathways in more detail, and then we'll have a question and answer. So I think the buzzword at the moment in health literature is the patient-centred improvements, and I think we have to know what they think because it is a service industry that we are in. We don't just have to think about what we think is good for the patient and what might be good for our service. We really need to pay attention to what's going to be useful for the patient. This is a Kaplan-Meier curve, which is the basis for all the colon cancer screening, and this shows data from the National Bowel Cancer Screening Program, and it compares the survival of those with colorectal cancer who have developed symptoms versus those who were screened with FOBT over a 5-year period. This is highly statistically significant, and it shows what can be achieved in screening rather than waiting for patients to develop symptoms. And this is despite a relatively low uptake of FOBT in the community. This is a slide taken from the Cancer Institute website. the age standardised mortality of bowel cancer in New South Wales over the last 40 years. You can see that there's been a lot of developments over this time in terms of increasing screening and better treatment for bowel cancer over this time, with an overall improvement in mortality, practically about half in the last 40 years. And further improvements are expected with improvements in treatment and increased screening. So if we can get them out there doing their FABT, these rates will probably improve into the future. There's a large variation in the rate of colorectal cancer in the geographic areas across New South Wales. Rural New South Wales and regional and remote New South Wales have a much lower, have a higher mortality from bowel cancer. Whether this is due to partially their increased risk or decreased access to services is not that clear. But there is in terms of access in Sydney, the very light mauve colour is particularly Sydney's eastern suburbs and the local health district around Westmead, which is a world-renowned centre for colonoscopy treatment. They seem to be doing a bit better than the rest of Sydney and most of New South Wales. There is a marked maldistribution of colonoscopy services taken from Medicare data, where you're 30 times more likely to have a colonoscopy if you live in Sydney's eastern suburbs versus outback Australia. So this is part of the reason why Australia does have a high rate, because we're not getting to the people who are going to have the most value from intervention. Astoundingly, I think, Medicare pays for 500,000 colonoscopies a year in Australia, which seems to be a very large number considering there's 25 million people here. And this includes all people from 0 to 100, not just who we would regularly be screening. So there's probably a lot of patients having colonoscopies and they're not of very high value. Something that I've learned over the last couple of years is that colon cancer is related to your socioeconomic position, and if you're a less advantaged person, you're 20 to 30 times more likely, 20 to 30% times more likely to die from bowel cancer than if you're privileged. And I think this is particularly important when we're looking at a public hospital service and improving the access. Unfortunately, bowel cancer is still a high rate, but much higher than other common cancers that receive a lot more publicity, particularly breast, melanoma, and prostate. So despite being a very effective program, there's a much lower rate of screening for bowel cancer than for breast and cervical cancer. And New South Wales only has about a 36% uptake of the National Bowel Cancer Screening Program. And this is lower than the other Australian states and territories. And Sarah McGill was one of the people at the Cancer Institute in New South Wales, saying that we need to correct the gaps in the awareness and increase the numbers of people screening to reduce the numbers of people dying. So why do people not do their FABT? And we need to ask why the patients aren't doing that. There is a study from South Australia reported a couple of years ago, which says that the most commonly reported reasons for doing FABT were as part of the National Bowel Cancer Screening Program, or if it was made part of the routine procedure with their family doctor. Whereas the reasons for non-use were not having symptoms, according to the patient or their understanding, and their doctor not advising the test. There is other anecdotal reasons which patients often talk about, such as their distaste for poo samples and having to transport them and the embarrassment involved with that. There's also the inconvenience, difficulty and unpleasantness of colonoscopy, and there's also the access and cost of colonoscopy. This has led to particularly the New South Wales government coming up with a program to improve the value of colonoscopy versus just doing lots of colonoscopies. And the rationale again is that 12.4% of cancers will be bowel cancer, but if they're found early, such as at Dukes A, they're much more treatable. 90% can be treated successfully. Another important point is that if you pick up bowel cancer early, and I think this is what the government's particularly interested in as well, is that if you pick up a cancer at Dukes A, your costs are 2.5 times less than if it's Dukes C. A lot of the cost involved in Dukes C is the oncology clinic with the drugs and their appointments. But already with screening increasing over the last few years, the oncologists have noticed that they're getting much less patients who need chemotherapy for metastatic bowel cancer, and that is encouraging. So apart from trying to get patients to do it, we're also looking at trying to improve the value of the colonoscopy that the specialists are doing. There's a number of things that are being done by various government and society bodies. Particularly interest to me is the colonoscopy recertification, which is run by Gastroenterology Society. And this is a recertification process where a colonoscopist will submit all their colonoscopies in patients over 50 and working out what their adenoma detection rate is. This is a very good marker of predicting whether a patient is likely to develop a bowel cancer within the next 5 years after they've had a so-called adequate colonoscopy. So if the adenoma detection rate is high, they're much more likely to have missed lesions, particularly missed cancer. This is something that's been sponsored by the Gastroenterological Society, and there is a website, which I've got the link at the end, for colonoscopists who have been recertified. This is an external audited process outside the practitioner's practice. And this needs to be colonoscopy needs to be recertified every 3 years rather than just saying that they can do it when they first train. So I think this is a big progress. The National Health and Medical Research Council and the Cancer Council also developed guidelines in terms of recolonoscopy after finding a polyp, and also tailoring which patients should have colonoscopy if they have a family history, and which patients should be having an FOBT. These are particularly on the Cancer Council website. There's a wiki which I don't find easy to navigate, but once you get used to it, you can use that to decide what you should recommend to patients, either an FOBT or a colonoscopy. Another committee I was involved with was mainly in terms of how the colonoscopies are distributed amongst the patients, is the colonoscopy categorisation, where patients are stratified in terms of the likelihood of them having pathology. This is particularly important at the hospital and local health district level, that prioritises patients who are most at risk rather than just which specialist is most insistent, who gets the colonoscopy first. Medicare have also been looking at how colonoscopies are used and are starting to define what ones they're going to be paying for. There's some new item numbers in the past 2 years, which is the first attempt to try and rein it in a bit. There used to be one item number for colonoscopy and one item number for colonoscopy and polypectomy. There are now about 10 item numbers for colonoscopy, depending on what's found at colonoscopy. So just as an example, there's a number called 3223, and this is for patients who are thought to be at moderate risk of bowel cancer. So these are patients who, I'll particularly look at the second item, which is patients who have had a polyp, but a low risk polyp, such as a tubal adenoma, which is quite small, and only 1 or 2 of them. And if these patients probably only need to have a colonoscopy in 5 years, although Medicare have been generous saying in 10 years, I should say, generous saying only 5 years. But if this is a way to limit so that if someone tries to do a colonoscopy within that time period, then Medicare won't pay for it. This is something that has probably fallen away a little bit, particularly with the pandemic and other things occupying the government. But I think over the next couple of years, it will become audited, and people who want colonoscopies are going to find themselves limited, and doctors limited as well. One part of the explanatory note is that you can only have a colonoscopy 5 years for moderate risk of colorectal cancer. And these definitions of who's at moderate risk are seen a couple of times. These are people who haven't got symptoms and just have a family history. And it's becoming more than just an aunt who developed a bowel cancer at the age of 70. Those people getting a bowel, expecting to have a colonoscopy. It's only really realistic if you fit these criteria, such as a first-degree relative less than 55 years, or 2 first-degree relatives, or at any age developing a cancer, or 1 first-degree relative and 2 second-degree relatives. So in particular, notice that you're not at very much increased risk if you haven't had a first-degree relative developing bowel cancer. So these people probably should be counselled that they don't need to go through colonoscopy and more appropriate for FOBT. Over time, I think the government will probably enforce this more. And I do mention this in part of the definition of the 3223, that we should be doing FOBT on patients outside this criteria because they're not meeting the definition of moderate risk. Another body is, there are lots of different bodies involved, but another body is the Australian Commission on Safety and Quality in Healthcare. And this is a clinician fact sheet to try and improve our services, the doctors improving their services. I think an important one is number 3, the informed decision-making and consent. And this has there been a number of legal cases about the definition of consent and how this is achieved. And I'd just like to read that because I think it is important in terms of how direct access colonoscopy works, is that before starting bowel preparation, a patient receives comprehensive consumer appropriate information about bowel preparation, the colonoscopy and sedation or anaesthesia. They have an opportunity to discuss the reason for the colonoscopy, its benefits, risks, financial costs and alternative options before deciding to proceed. Their understanding is assessed and the information provided and their consent to sedation, colonoscopy and therapeutic intervention is documented. I think a fair bit of the time we sort of assume that is happening, but I think we need to make sure that that is happening. The same body has made attempts to improve the patient experience as well. So things like sedation, which I think the general public not that aware of how sedation is done. A lot of people still seem to think it's a twilight rather than a full anaesthetic. So this is a document that's given to the patient, or our service will be given to the patient, talking about what they expect from the different stages in their care regarding colonoscopy. This one is particularly highlighting sedation, that again, they're talking in detail about how this occurs and encouraging to discuss with their carers. There have been a couple of other improvements in the patient experience of colonoscopy, which, based on evidence, a few things which patients seem to like is that it's no longer necessary to have a clear fluids the day before the colonoscopy. You can have a low fibre diet for the whole day until the first prep. Another development is some low volume preps, which are of 1 litre rather than 3 or 4 litres. Some other developments are you can have clear fluids until 2 to 4 hours before the colonoscopy rather than fasting from midnight. There's also a split preparation, Another important thing is taking the preparation the minimum amount of time before the actual colonoscopy. So this means for people who are having morning colonoscopies, it's getting up at 3 or 4 a.m. This does improve bowel prep and polyp detection. Other things we're looking at doing is like these talks, and also hopefully improve communication with email and faxing rather than mail, general information to patient and GPs, and also telehealth appointments, particularly with COVID. COVID has really stimulated the telehealth appointments. So as a direct access colonoscopy service, this is different to an what's called open access colonoscopy, where the colonoscopists, admitting staff handle the booking and don't review the indication and the patient comorbidities, or a healthcare worker doing the consent. This is different to how a direct access colonoscopy works. Direct access colonoscopy involves the GP referring to the local hospital outpatient clinic. This is generally by them directly faxing to the clinic, and then the clinic contacting the patient rather than the patient contacting the service. The referrals are triaged by the consultant or the RN as appropriate for DAC, and then the RN runs the virtual clinic, or what's been retermed DAC, therefore bypassing the need for the patient to have a clinic appointment. There's a lot of work has gone into pro formas to explain the process of the whole organisation of colonoscopy, the preparation, the risk and the scheduling, and this is all conducted by phone, video, SMS and email. Another important part as far as the GPs are concerned, of course, is the RN communicating the results and the subsequent plan to the GP, and this intended to be closely supervised by the consultant. I think big difference with this with open access colonoscopy is that the person doing the colonoscopy is taking responsibility for and is expected to take responsibility for which patients come through their service. In open access colonoscopy, there's a risk that patients haven't either prepped properly or consented properly, or they're not appropriate. So this is trying to limit that. So therefore, developed an inclusion and exclusion criteria for DAC. This is to try and again improve the safety and access. This is mostly for positive FABT, but can also be used for people who have a background of chronic adenomas and family history, if we've got those details. People who are appropriate for a DAC are if their patient doesn't have any, doesn't expect symptom, or the GP doesn't expect symptom assessment or management by the specialist, the patient's comfortable with not meeting the specialist before the day of the colonoscopy, and assessment instructions are by telehealth. Another thing to think about is if you as a GP are okay to discuss results and future plan after colonoscopy. One point about finding major pathology such as cancer and advanced polyps is that we intend to follow up these patients ourselves. So in terms of managing repeat or explaining and then managing repeat colonoscopy for a possibly incompletely removed polyp, or directing the cancer treatment if that's what's found. Unfortunately, the exclusion criteria is quite long, and I don't mean to daunt you with this, but I hope most of it's is more just pointing out the obvious, I think, and just defining it. But there's some things which do make direct access colonoscopy difficult in terms of getting adequate consent for the patient. These are things like particularly anticoagulants, because there's different indications and risks for stopping anticoagulation. So these need to be discussed with the patient in detail, which can't be expected to be handled by an RN. Things like recent heart attack, or if they haven't got very high anaesthetic, haven't got very good anaesthetic risk, or if they're very over, such as also including being overweight, or if they're unable to give their own consent. Another situation where DAC wouldn't be useful is if a patient might have severe anemia or need an iron infusion, as the pros and cons and discussion regarding iron infusion or blood transfusion would need to be undertaken. Some of the things that are acceptable for a DAC is if patients do have minor symptoms which don't require specialist input and aren't affecting daily functioning, such as and including if they've got mild to moderate or well-controlled upper GI symptoms. Low-dose aspirin, if it's as for secondary prophylaxis, is appropriate. People of Aboriginal and Torres Strait Islander origin, if there's reduced English proficiency, most DAC services are happy to manage this by phone interpreter. Patients outside of 50 to 75 years coming to a DAC is a little bit problematic, but if they're very in good health, we would also consider those. I'd like to present a couple of case studies, and I was hoping that the audience might be able to give their thoughts on some scenarios that what they do with a patient in these scenarios. I was hoping that the audience might offer their thoughts, moderated by Dr. Dwyer. So if there isn't that much contribution, I can discuss them myself. So first patient that I think is a less than usual situation, but does come up, is a 76-year-old who, say, is new to the practice and then has never done an FOBT, and whether they should have an FOBT. I can go through these if people don't want to volunteer, but I think if people, if someone who's, although the National Bowel Cancer Screening Program goes from 70 to 75, I think if people haven't ever done screening, they probably should have a couple of FOBTs if they're in good health. So I wouldn't deny people who were never done an FOBT, a colonoscopy if they're over 75, particularly if they're in good health. That would have to be organised through your local pathology or chemist. The next situation.
Sorry, Dr. Hall, we had one comment coming through, depends on other comorbidities.
Yeah, that's right. It does depend on other comorbidities. I think if people have, it depends on the number of comorbidities and the patient's attitude to taking the risk of a colonoscopy. If they have more than one comorbidity, I'd be very, very hesitant, such as major comorbidities like diabetes or coronary artery disease, for example. But if they're in otherwise good health, I think it should be done even though it's not as routine. For a 76-year-old who has been doing FOBT every 2 years, I think it's a similar situation if they're in extremely good health and they don't have more than one, either naught or one comorbidity. I think it's a consideration. Another situation is a 57-year-old who comes to you with having done the National Bowel Cancer Screening or done a cance kit with them, and they've turned up with a positive FOBT, despite having had a high quality colonoscopy showing diverticular disease about 3 years ago. Whether this patient should have another colonoscopy. It really depends a lot on whether they do have any other symptoms, and I think you have to go through this in a lot of detail, where there are other symptoms and what the reasoning for doing the FOBT again was. It also depends on how confident you and the patient are in the quality of the colonoscopy that was done 3 years ago. If the colonoscopist is accredited, then you've got more confidence in saying it doesn't need to be repeated. If you don't know the colonoscopist or they're not recertified, then I'll be more hesitant in saying that they shouldn't have a repeat colonoscopy. Colonoscopy isn't a perfect test and there are misses. So I'd I think that patients should be kept under close observation and the pros and cons of repeating colonoscopy. It's a little bit different as a colonoscopist. You really can't, because you can do the test, people coming in for you to ask your opinion, and the only real way you can find out is to do the test again. But you might be able to explain it at the family practice level that, you know, the actual figures are that you're probably not needing another colonoscopy. So do you want me to answer some of the chat questions now, or we'll do it at the end? I'll keep going. There's another situation is whether we should be doing FOBT in people younger than 50, such as people who are at high risk for bowel cancer, such as, like this example is a 46-year-old who weighs 115 kilograms, does little exercise, has diabetes and 4 beers a day. This person is and no family history, this person is at quite high risk of developing bowel cancer, and although at the moment we don't stratify according to the individual's risk of bowel cancer, this person probably is at higher risk in reality, maybe should be having an FOBT. Another slight change in how we're managing family history is, in the past, if a next patient was a 47-year-old with a first-degree relative with bowel cancer, who had a 58 and a second-degree relative with a bowel cancer at 72. In the past, the guidelines would have said that person should have a colonoscopy every 5 years once they turn 40, but the current recommendation from the Cancer Council Wiki is saying that they should have FOBT every 2 years starting from the age of 40, and then colonoscopy every 5 years from the age of 50. So this is another situation where we do an FOBT is recommended outside the usual 50 to 75 age group. Another situation is where we shouldn't be doing an FOBT, I think, in someone who is of the screening age or usual screening ages, if their functional age is higher than their actual age. Say someone with severe COPD who can't walk up a flight of stairs without stopping, and presumably their life expectancy might be less than 5 years. This sort of person is not going to probably benefit from colonoscopy, because the benefits from screening only really start becoming apparent at about the 5-year mark. So you're likely to be doing a colonoscopy on someone who, even if you happen to detect a couple of polyps, they probably would never have lived long enough for them to actually come to grief with those polyps. So I think,
sorry, I'm having trouble with the internet at the moment. Did you want to go with any of the questions now, or keep on going?
I'm happy to go now. But we did say we'll do the question and answers after the talk and after Martina's talk.
Okay, that's fine.
I wasn't sure what the uptake of people volunteering their thoughts online or verbally would be. So there is a report of the local experience of DAC in the St George region rather than Sutherland region, and this is the median wait time for people to have a clinic appointment and also to get their colonoscopy. So this was where it was termed virtual clinic versus pre-virtual clinic, as in the DAC, pre-DAC, and there's a marked decrease in the time that patients get into or get spoken to by the service, and also the time that from their initial FOBT to their colonoscopy. That also frees up clinic time to look at other gastro situations. Importantly, even by doing DAC and with a nurse, and probably even better than doctors talking about the bowel prep, is that 93% of patients had an excellent prep or a good prep, and generally, I haven't got the details here, but there's very high patient satisfaction with a DAC service. That's from the local community. There's increasing data from all sorts of places about how much benefit there is from screening versus symptomatic patients. This is something that was published only a couple of months ago about the benefits of, even in the short-term mortality, of screening versus symptomatic patients, with a benefit of relative risk of 0.31 in terms of 33-day mortality from surgical literature. This is Australian New Zealand data where 24% of bowel cancers are uploaded to this registry by colorectal surgeons, and in New Zealand in 2019. So there's less 30-day mortality and also reduced length of stay. So in terms of how also that when we do screening, we tend to pick up the cancers in the earlier stage. So people who have screening tend to be localised, while people who don't have screening, which is the who haven't done their national bowel cancer screening program and end up with a cancer, they're more likely to have metastatic disease. This is just outlining again the family history and the use of FOBT, which I talked about before. So I think these things keep changing and it's hard to keep it in your head what are the criteria. And I think my practice is just to keep looking back until it sinks in, looking at the Cancer Council Wiki and the National Health and Medical Research Council data or guidelines, so that we make sure we're doing the colonoscopies for the right people. So in terms of referral to the Sutherland Hospital Direct Access Colonoscopy, we have developed a referral form. This is available on the health pathway, and the people involved are a DAC nurse who is Anna Kunz, and the specialist most directly involved is Dr. Wasim Rahman. But these can be then, they're populated from most GP practice software, and then that can be either faxed or emailed to those addresses. Although you have to point out to the patient that emailing is not encrypted, so they'd have to give consent to that. And then these are taken and then assessed for appropriateness for DAC, and then we'll take it from there. A couple of things that are useful to have for us prior to their referral is having a full blood count at 9 studies. A lot of patients do end up having to have having a gastroscopy with their colonoscopy, whether all of them are appropriate, but particularly if someone is iron deficient or anemic, they're much better to have a gastroscopy at the time of their colonoscopy rather than having it at another time. So a full blood count 9 studies before with their referral would be helpful to try and pick those patients. I think another thing is that often isn't talked about is colonoscopy as a screening test, and it is thought by a lot of patients, it seems, that they should have a colonoscopy rather than FOBT. And I think the government guideline and the evidence is that people should be having FOBT rather than colonoscopy. But I think a colonoscopy in someone who's not going to do an FOBT for whatever reason is better than not doing anything. So I think we have to have a discussion with the patient and talk to them about the options for screening, that they need to do should be doing some form of screening. And if they choose colonoscopy, I think they should be allowed to have that as their primary screening. So in terms of the GP role in fecal occult blood testing and colorectal cancer, I think the big things are encourage the patient to participate. And I think making this part of the, hopefully might be annual review, checking their blood pressure and their heart, blood pressure and their cholesterol and their sugar. I think asking about whether they've done their FOBT and asking about symptoms of bowel cancer, and also every few years asking about their family history, knowing about the availability of direct access colonoscopy and how this can facilitate the process, because it is difficult getting a yucky test and then having it, as in the FOBT, then having to see a specialist and then or wait in the hospital queue. So now we're trying to fast track that to make it easier. Personally, I think GPs should look at what reminders are sent from specialists to see if they are actually valid. Just because a specialist says it has to happen doesn't mean it is always right. And you might not have access to all the information, but I think someone getting a colonoscopy every 1 or 2 years without a family history or any polyps is not appropriate. And that I think validating and taking some responsibility on the patient's behalf I think will be increasingly appreciated by patients. I think there are some lifestyle measures to reduce bowel cancer, where they're not big, don't have huge impacts, but they are important, or are important enough to mention to some people as they want to improve their risk. And I'll talk about those in a sec. I think explaining the results of colonoscopy, most of them will either that you'd have to handle would be either a normal colonoscopy and what that means, and meaning that if you've had a high quality colonoscopy, you're unlikely to develop bowel cancer in the next 5 years, and that you probably don't need to do any form of screening in that time. But also pointing out that it's not a perfect test, and if you develop symptoms, then these need to be looked at. So, and that unfortunately at the moment, reminder mechanisms in the public hospitals isn't very good. So I think keeping a record of when their colonoscopy is due, if it's not done through, particularly if it's not done through VMO rooms, in terms of recalling the patient, because the public hospital doesn't seem to have the facility to do it as yet. And particularly discouraging doing FOBT in the first 4 or 5 years after colonoscopy, particularly the ones that just arrive in the post, and the patients do it and then they get a positive, and then you've got the difficult situation of deciding whether it's real or not. Some of the risk factors for bowel cancer you may or may not be aware of is obesity is a definite risk factor. Diabetes, these are all relative risks. Red and processed meat, also similar risk, about 1.1. Smoking and alcohol. Some patients want to do stuff about this, but I think they should be at least told what, and these apply to a lot of illnesses, of course, but a lot of patients do want to know about those and do something about it. Protective factors are physical activity, fruit and veggies. Interestingly, fibre isn't that protective, and things that have been said to be protective in the past, such as calcium, folic acid and aspirin, either don't work or have increased risk. So now I'll stop sharing and Martina will present on health pathways. And we'll have question and answers after Martina.
Thanks, Matthew. I'll just bring my screen up too. So I've already spoken to many people in this group about health pathways in the past, but it's always nice to remind you of what's available. And we've been working very closely with Matthew to make sure that we've got a really good pathway on fecal occult blood testing, and also on colonoscopy, and also the gastroenterology referrals. So I just wanted to show you those pathways. I'm hoping you can see my screen, because it doesn't seem to be.
Yes, you can.
That's great, but it's stuck. It's not actually moving on. Oh yeah, here we go. So here's the link for the classic site of the health pathways, which is actually the best one for desktop. And I've put a QR code because we're all getting good at them. And those of you who are watching, if you throw your phone up and look at that QR code, it'll actually take you to the Health Pathways website, where you can use your username of SE Sydney and your password of healthcare to log on to the site. And I would suggest that you save the password in your browser, because then you won't have to keep remembering that pesky password. We also have a mobile-friendly site, which is a bit cleaner, and it's easier to see in a narrower screen. And so that's more suitable for your mobile phone. And so you might want to scan that one, because on your phones, the health pathways are going to show up and look a bit prettier on your phone. As I mentioned, we have gone live with 3 new pathways in the last month regarding this subject: the positive FOBT pathway, and the colonoscopy pathway, and the non-acute gastroenterology assessment. I just want to explain that in health pathways speak, when you see something like non-acute gastroenterology assessment, the assessment means referral, but the health pathways people don't use referral. And non-acute means this isn't something that needs to go to emergency. So sometimes if you're looking, you'll see acute gastroenterology assessment, and that would be defining the terms that mean this person needs to go to ED, and it will take you with the information on how to contact your local ED. And the non-acute ones will be divided into public and private, and that's for people who might need to be seen this week but don't need to be seen in the next few hours, and how to contact those people. Or it might be, yeah, they don't need to be seen this week but they need to be seen. So I now want to show you a live demonstration. It's actually really lovely that we can show that, because in the past we haven't been able to do live demonstrations in Hazelhurst because there's no internet there. So I'm hoping that you are now looking at a live screen that is scrolling up and down. Okay, so I'm assuming that you are. And if you can, you nod if you can see the live one. Great, thank you. So this is the home page. Sorry about my trend coming up. And this is the front page. So there's a number of different ways that you can search for what you're looking for. One is to guess where you think it might be. And so you might go to medical and say, if you're looking for something in cardiology, you can click on cardiology and click one of those pathways, and that'll take you to where you want to go. In this case, if we're looking for FOBT, it might be easier just to type in FOBT and search. And that will take you to positive fecal occult blood test, which is our new pathway. And there you are, up it comes. Just this little icon means that we've got some information that's relevant to Aboriginal and Torres Strait Islanders on the page. And those of you who've used health pathways before will be familiar with the idea that we have drop downs. So when you see a little plus sign and you click on it, you get a lot more information. And the reason why we don't have it all spread out and we nest things in drop downs is because we really want you to be able to scroll down not too far and find the information that you're looking for. So I won't take you through all of the complete pathway, but it tells you what to look for in your history. Like all pathways start with an assessment, and then once you've done your assessment, how to manage it, and then link you into the request or the referral pages. And there's also information down the bottom for health professionals. We found a really helpful flip chart for Indigenous bowel screening that explains the process to Indigenous people, which is quite helpful. And also there's some information that you can link to and either email to the patient or print out for the patient to help them understand what's going on, because we all remember that patients forget half of what we're telling them in a consultation. Now, if we were looking for the colonoscopy page, again, we can do a search. And there we have that. And I'll just show it to you in the mobile-friendly version just so that you can see the difference between the two. There you go. So because this is what we call a request page, it doesn't have the assessment management. It just has the information for how you can find the clinic that you want. So we've subdivided it into public and private. And we've got public outpatient clinics where, you know, you might have decided the patient isn't appropriate for a direct access colonoscopy, but that they do need a colonoscopy and they may even need a gastroscopy as well. So in the public outpatient clinics, you can check the criteria. And Matthew was mentioning the Australian Centre for Clinical Innovation, how they've streamlined the expectation of when people with certain conditions will be seen and who should be seen in the clinics. And we use those guidelines to set up this criteria, so it actually meets the current guidelines. And you can take this through if it talks about critical factors that might mean that the patient needs to be seen within a month, or symptoms that mean that the patient might need to be seen within the month. So it takes you through, basically you can work out the algorithm of when you might expect the patient to be seen and when to tell the patient that they should be able to be seen. And after you've gone through the criteria, and I'm just going to put that away, it also tells you what the required information is. And sometimes that's just your standard information, you know, all of the patient demographics, the reason, their history, the current management examination findings, investigation, the sorts of things that you would be putting into every referral that you write. But sometimes there's specific information that, that the clinics will particularly need. And in this case, they need a body mass index. They need a copy of the original National Bowel Cancer Screening Program result, because that's got the patient's individual number on it. And then the person doing the colonoscopy has to provide a report for a positive FOBT back to the National Bowel Cancer Screening Program. And if they enclose the number, it makes life easier for everybody. And then there might be particular tests that they need you to send in. So that's all there, which makes the handover of care from primary care to secondary care easier, because you've provided all the information. It's easy for the nurse to do the triage, and easy for the people allocating appointments to get the patient in the appropriate amount of time. And then this lovely little contact the service, which expands out and helps you identify the clinics. Now, these are the clinics. This is not the direct access colonoscopy. These are for the people that don't meet the criteria for direct access. So we've got information for how to refer to Prince of Wales, for those of you who might be joining us from the Prince of Wales area. St George and St Vincent's, they've got a number of clinics, including a liver clinic, but this is their general one. And then I didn't know until I was actually preparing this page, Matthew, that you had a gastro clinic at Sutherland, and it's such wonderful news that one exists. And so now that we know, and now that you're on health pathways, you can't hide. People are going to be able to find you, which is great. So there's the information, and it's mostly Dr. Rahman who's working there, so you address the referral to them. And then down here we've got the direct access colonoscopy clinic. So again, the criteria is a lot more simple in some ways, or more difficult depending on what the comorbidities are. The criteria is asymptomatic or fit and well patients with a positive FOBT. And again, the required information is the same as above, actually. Take note of if the patient's taking any complementary medicines. I think that's because some of them make people bleed more. And then the 3 direct access clinics that are available. Prince of Wales also has a kind of direct access service. You send the referral in the usual way to the doctor, and the doctors do the filtering. But these 3 services are actually run with a nurse-led model, with a proper gastroenterologist doing the actual scope. So there you are, you have the contact details and the referral form for the direct access service at Sutherland. And I hope it goes really well, Matthew.
Yeah,
there's a couple of other pathways that we're developing right now. One is for bowel cancer screening, so that will help with that, working out who's at normal risk and who's at moderate risk and who's at high risk, according to the new wiki guidelines on the Cancer Council website. And I think we're also going to have one on follow-up of previous colonic polyps, because that can be a bit confusing. And we may develop one for colorectal symptoms. We'll see how we go. That's going to require also identifying the colorectal surgeons, so that might be a little bit longer in coming. So that's health pathways and colonoscopies for you. And I'm happy to take any questions if people have any about health pathways. So thanks for giving me this opportunity. I'll stop sharing now.
All righty, are we ready for questions?
Yes.
Okay. Not that many. I'm not sure whether they've all come through. As I said, I've been having trouble. First one, does National Bowel Screen list out all the potential signs and symptoms related to colon cancer when they send out the thing? I don't think they do, really, do they?
They don't talk about symptoms. I think that's...
Sorry, it's a screening test. And screening tests are by definition for asymptomatic patients. So if you've got a symptomatic patient, you can do an FOBT, but it's not the National Bowel Cancer Screening one. That's for people with no symptoms, just like cervical screening is for people with no symptoms.
I think that's also for patients, like if they get a negative, they think, and you know, there might be different reasons why the patient actually does do it. They might have symptoms that they think might be bowel cancer, and they happen to get that thing in the post, and then it's negative, and they think, oh well, I haven't got bowel cancer. But I think they, but that's not true, because it's not a completely accurate test. That's so I think, you know, those sort of things, the interpretation of it, I still think has to be discussed with their doctor, because patients just don't know how to interpret. Or I think having a negative, I think they should discuss. Patients should discuss a negative with their doctor as well, not just, you know, throw it in the bin once they get a negative, because there's all sorts of different reasons why they might do it in the first place, or they mightn't be aware of the things they've got to look out for when they've got bowel cancer, or don't know that they've got to find out about their family history if they can. All these sort of things that need to be discussed with them as well. So I don't think the National Bowel Cancer Screening Program is trying to, you know, talk about the symptoms of bowel cancer. They're purely just sending out the test and hoping that the patient will do it.
Okay, that's good. Relating to that, is the National Bowel Screening Program, do they still send fecal alcohol blood tests to if the patient had a colonoscopy in the last 2 to 3 years that was clear? I think they still do, don't they?
Yeah, they do. You have to actually
opt out.
Opt out, which I don't know. I haven't tried to do that, but I imagine from other government things it's hard, and someone has to sit down and spend 5 or 10 minutes doing it. So that probably most people don't. But there's no link between, you know, you think there'd be a link between Medicare paying for colonoscopies and the National Bowel Cancer Screening Program, but there isn't. So they just keep getting them sent out. So that's why I think if they do get a test, or particularly if they've had a colonoscopy, we should counsel them not to do the FOBT within that 4 or 5 year period. They can restart after the 5 year, 4 or 5 year, presuming they haven't had an adenoma, when they're going to have a repeat colonoscopy anyway.
Another question relating to fecal alcohol bloods and the colonoscopies. Often nowadays we're told that, oh, the colonoscopy is okay, or there's been a polyp, and for another colonoscopy in 5 years' time, but to ensure they still have their fecal alcohol blood test done in 2 years' time, or every 2 years. What's the thinking behind that?
Every year.
Yeah, I think I have seen some doctors saying that, but I don't think that's based on evidence or recommendation. I think that's a fear or a belief or something, I don't know. But definitely the way I understand the recommendation is that and the guidelines and the evidence is that if you've had a good quality colonoscopy, any repeat positive FOBT within 5 years is likely to be a false positive, meaning that you could repeat the colonoscopy and you wouldn't find anything again.
Yeah, so I think that's going to be an area of debate with a lot of us because, as I said, a number of us are getting that recommendation from other people, and then it's difficult to institute sometimes as a GP.
Yeah, I think it is hard to. I understand how, you know, that's the letter coming from the specialist that, you know, it's hard to sort of go back on that, but I think, and it's hard to take them up on it as well, but yeah, I think you have to be honest with the patient and say that, you know, this is now, I know this is what your specialist said, but it's not the way I interpret the guidelines.
Well, I tend to agree with you because I'm obviously not an expert, but if it was positive and then they've been tested and there's nothing sinister, the likelihood of repeating the test in a year or two's time is you're going to get a positive anyway, and they're due for another colonoscopy in 5 years' time. So are we being redundant?
Oh, definitely. Yeah. I think it's, I just don't understand why some doctors, some gastroenterologists or surgeons do that, because I think it displays a lack of understanding of the characteristics of the tests. I think, you know, colonoscopy is an inconvenient test. It's also difficult and has got some risks. So I don't think you want your patient doing it unnecessarily. And if you're getting a clanger like that, well, I think that's a clanger. I think, yeah, we should, as GPs, you should, it's easy for me to say, but start taking it up that, you know, this isn't appropriate. It is hard to counter it, I understand that. And, you know, if you rely on your referral network and so forth for backup and to help out with other situations. But I think, you know, we probably should try and start doing it just for the patient's sake, like patients who, you know, someone's retired or someone's moved out of the area or something like this, and you get a patient comes in for their next colonoscopy and you find out what they've been doing, and they're getting a colonoscopy every 1 or 2 years for someone who, you know, had a, you know, very low risk polyp or very shaky family history. That's just not fair to the patient, I don't think, like talking them into doing lots of unnecessary tests.
Thank you. The other thing was you mentioned it there in things that might predispose to bowel cancer and preventatives. You mentioned that the aspirin used to be thought to be preventative, but it hasn't been shown to be that beneficial nowadays. And but someone mentioned that there was a whole article in the Journal of GPs recently about aspirin as prophylaxis for colorectal cancer.
Is that people who've already had cancer?
What was the question, Matt?
Sorry?
Is that for people who have already had bowel cancer or the general public?
Um,
Oh, sorry, I don't remember seeing that, but it's almost...
It's in as prophylaxis for colorectal cancer.
Yeah. I'm not sure if that's like a general population thing, or is it like someone who's had cancer and then getting their next cancer?
As I said, I don't know. That's just a question that came in.
Yeah.
I don't know the actual article.
It's been pretty hard to show that aspirin does make a difference, even in people who have got very high risk of polyps, such as people with FAP or Lynch syndrome. It's very hard to show a benefit from aspirin, even in people like that, in terms of preventing polyps. So I can't imagine that it's going to be a value in like just the standard population, low risk people. And the same things happen with aspirin in terms of reducing cardiovascular outcomes. Is that unless you've had a symptomatic cardiovascular, like coronary or cerebrovascular event, then your risk of aspirin is higher than the benefit you might get out of it.
Will the services accept patients living outside the southeastern Sydney health area?
Yeah, we do. There are some talks about, I was at a meeting with the South East Sydney Local Health District about this issue today in terms of trying to reduce what we have to do by cutting off people from out of area, but that's not the policy anymore. Because,
Okay, thank you.
because just as many people keep turning up at different areas, and other areas do as many of our patients as we do of theirs. So it sort of evens out in the end anyway. So that out of area thing seems to have fallen away again.
That's good to hear, because in a lot of other health policy things, there's a no wrong door policy, which means as soon as a person enters, they should start getting the treatment they need. But there has been a lot of restriction. I just wanted to also answer to that question that Sydney Health Pathways, and you can access them using the same username and password as you need for South East Sydney. Sydney Health Pathways has a colonoscopy referral page as well, and RPA Hospital has a DAC service. Concord Hospital doesn't. So that might help your patient who lives in the inner west. And there's a lot of people who live really close in between, like in Green Square. One side of Moore Park Road is South Eastern Sydney, and the other side is Sydney Health District. So we have to let people go where their GP and they are comfortable.
In terms of, Sutherland Shire is like a wealthy area and, less risk of getting bowel cancer. While some of the, like St George, for example, because there's talk of like banning people from St George area coming to Sutherland.
Oh, really?
But I think, it's a good thing because, help with their waiting times and things, because they're, got big waiting times and we haven't got relatively high waiting times, and they're the most people who are less likely to benefit. So my personal feeling and what I got from the administration today is that, it's probably a good thing that we're doing out of area, because they're likely to be coming from areas which are less well serviced than we are.
All righty, I'm breaking up a little bit at times, but the question again, with direct access colonoscopy, most of the times the colonoscopy is done by the specialist or the registrar?
It's done, the specialist takes responsibility for it, and the registrar might do it under very close supervision. The consultant is in the room at all times, and particularly if there's a difficult polyp that's very closely or done by the specialist if the registrar isn't thought to be competent. But we're watching this as we're watching the screen as the registrar does it, and telling them when they're not doing what they should do and so forth. But I think it's not as good as if the specialist is actually handling it, or suspect it isn't, but it's pretty close. And particularly with difficult situations, usually it's the specialist who does it in the end anyway. It mightn't be done by the specialist, their named specialist either, which is a little bit of a difference in terms of coming to the clinic. I think in terms of equity, if you see a specialist in the rooms, you think that you're going to imagine that you're going to get the specialist be on the specialist list. But through the clinic, and I think there should be, and some specialists have got longer waiting times than others. I think coming to a public hospital, the usual sign off is that you get the colonoscopy done by someone competent, but not necessarily the doctor you're expecting to. I think that's a good thing in terms of, people waiting around for someone who they believe is a fantastic doctor or something. But it'd be better off if they got their test earlier. So I think most colonoscopists probably, and particularly with ones that are accredited or recertified, are probably doing a pretty similar job to all the others. So I think that's a good way to, get people in quicker rather than having to wait for the specialist that they believe that is better. But some surgical procedures, and it's a different approach that maybe the surgical registrar is left to do a lot more then probably a gastroenterologist would let do. But as a gastroenterologist and I think surgeons doing colonoscopy, there's a pretty close eye on what the trainee is doing.
Mm-hmm. Okay. I think that seems to be. I think that seems to be most of the questions at the moment that we've got, and probably what is the waiting time for at the moment for direct access colonoscopy? Those times.
We've only just started the service, but we're hoping to. And one other point I wanted to make is don't be scared about if someone's outside of what you believe might be the inclusion or exclusion criteria. Just send the referral anyway, and we'll take it from there. Because if someone you think might be borderline or they're really the easiest way to get it sorted for the patient, even if you know they're outside the acceptable criteria, just send the referral anyway, and we can, if we decided they're not appropriate for DAC, we'll book them into the clinic. I think that way of getting the referral to us is something we'd like to develop in any case. So, if there's some question about it or you're not sure, just send the referral and we'll sort it out. We'll get them into the clinic and get them seen by the specialist. But we're hoping to turn it around pretty quick. So we get the referral and then the DAC nurse will arrange an appointment for within a week, and then the colonoscopy should be done within 30 days. That'd be the ideal. And I think we'll be able to achieve that. Something that's certainly in the next 4 or 5 months, the government has done or was stimulated by COVID, private-public collateral care or collaborative care, it's called, where access patients who are outside the waiting times at the public hospital are being done in the private hospitals by the same specialists. So people are being done in Carina Hospital and Kingsway Day Surgery, public patients, to keep the waiting list down. And it's looking like something like that might happen post-COVID as well. Certainly it was originally going to be just till the end of 2020, this collaborative care thing, but it's been continued until the end of June this year. And the way administration's talking is making sure that we're keeping the waiting times down. Traditionally, however, before the last year, or with COVID and all these collaborative care thing, if you had a positive FOBT, you might wait 3 months to get be seen in the clinic, and then another 3 months to get your colonoscopy. And the problem with that is that once you get to if you had a positive FOBT and you wait 4 or 6 months to get your colonoscopy, you're more likely to have metastatic disease by the time someone picks up your bowel cancer. So it does make a difference getting them done in the proper time frame in terms of patient outcomes. So we're looking at really having those numbers so we can keep going back to the admin and say, we're breaching time frame or benchmark, so we need to send more patients to the collaborative care or put more lists on it at the public.